Hi, this is Doug Rex. Today we're going to discuss the underwater EMR techniques developed by Dr. Ken Binmoeller for the resection of large colorectal polyps and flat lesions. When we're performing endoscopic mucosal resection with the lumen insufflated with gas, the approach is typically to inject fluid into the submucosa in order to get distance between the polyp and the muscularis propria. Our goal is to resect the polyp and keep the muscularis propria intact and uninjured. We don't really know the shape in most cases of the muscularis propria when the lumen is insufflated with gas, but we know that submucosal injection seems to be helpful in creating a safety distance between the polyp and the muscularis propria. Ken Binmoeller developed his underwater EMR approach based on the endoscopic ultrasound observation that when the lumen is filled with water rather than gas, the muscularis propria consistently has a nice circular shape to it, and there's a natural separation between the mucosa and the muscularis propria, suggesting that we don't actually need to inject fluid into the submucosa to create separation between mucosal lesions and the muscularis propria. So it was really this EUS observation that led to the development of this technique, which is fundamentally different from EMR with gas insufflation because it doesn't utilize submucosal injection.
We'll be using the cautery settings recommended by Dr. Binmoeller. Cutting current, so the settings are auto cut, effect 5, maximum watts 80.
So here's about a 15 millimeter lesion in the ascending colon seen with gas insufflation, and then we're going to remove the gas by suction and fill the lumen with water, and we're doing this with the water jet. So we're on the water jet and in some cases just pumping water continuously in order to keep the lumen full. And then we're going to perform EMR without submucosal injection. In this case, we're using about a 15 millimeter snare. You can see we've taken out the polyp and a little rim of mucosa around it. And there's the defect after the transection using auto cut. And the edges are clear, no residual lesion. Some of these underwater resections that I'm going to show you are from my initial experience, which I think is useful because we're all sort of beginners at the present time with this, except perhaps Ken Binmoeller. Now, this is a kind of lesion I found it to be often helpful in, one that is scarred down. About half the lesions that are referred to me have some degree of scarring from a previous attempt at EMR, and this one has some scarring along the right-hand edge, and the snare seems to dig in along that scarred area a bit better underwater than it does in gas insufflated EMR, perhaps because that tissue tends to float a little bit. But I didn't get it all. You can see that there's some red tissue right there on the edge closest to us, and then a little bit of residual polyp there. Ken Binmoeller has advocated marking the lesions with APC. Once you get underwater, you can delineate the edges of the lesion by APC marking. APC will work fine underwater, just like the snare works fine underwater. I found that generally I feel I can see the lesion still quite well. That little red area there we're resecting with some surrounding mucosa. So we're ending up with a piecemeal EMR, but we're still getting an effective EMR without performing injection. Moving to a slightly larger lesion in the ascending colon, please notice that the bowel wall with the underwater technique looks relaxed. The folds look relaxed. The polyp and the submucosa seem to move into the center of the lumen a bit, sort of float on their own. I think that's important to the safety of the technique. It's a good thing to look for during the technique. We are removing this lesion piecemeal, but Ken has described removing 2 to 4 centimeter lesions on block using a 33 millimeter snare underwater, and the feasibility of that is probably because with this technique the lesion doesn't get bigger. When you do submucosal injection, sometimes these lesions will double or more in size. That doesn't happen underwater. I'd be careful initially in what size pieces you take and look for this relaxed configuration. Here's a very large lesion in the distal ascending colon and hepatic flexure. This lesion occupies about a quarter of the circumference over parts of it and extends over 6 to 7 folds. So it's really a very large lesion. I just want to demonstrate that you can use this underwater approach even for very large lesions. So we're beginning our piecemeal EMR here without submucosal injection. Now, this lesion is so large that we perhaps should have considered marking the perimeter on the normal mucosa 2 to 3 millimeters away from the edge of the lesion, and then we would use those marks by extending the resection out to include them to make sure that we had a complete resection. But I found that during the procedure with a very high definition instrument and an image which is really better, of course, than the one you're seeing here, that I can actually track the edges of the lesion quite easily. But I just want to point that out, that that's available to you. APC, as I mentioned, works quite well underwater. You just march right up to the mucosa, normal mucosa, and tap it, and you'll get a nice, well-defined APC mark. And so it works in the same way that your snare electrocautery works underwater. Now, a lesion this size, of course, we're going to remove it in a number of pieces, probably 15 to 20 pieces. But I think actually the number of pieces is reduced compared to a traditional submucosal injection EMR with gas insufflation, because the lesion tends to stay smaller. So we're now cleaning up the edges as we get to the end of the procedure. Of course, we're going to carefully inspect the perimeter of the lesion and the base and remove any residual tissue that's present. There's a little red area there that's actually residual polyp. The other red thing is a vessel. But we go around the perimeter carefully, clean up the base, and then we've completed this underwater piecemeal EMR. You might be wondering whether I personally have switched entirely from traditional EMR techniques to underwater techniques, and I haven't done that. I still find the traditional techniques to be very useful, and I look forward to and anticipate that many centers will do comparative studies looking at speed of transection, ease of resection, outcomes like efficacy and risks between traditional and underwater techniques. But something that I've done at times is a sort of a hybrid approach. I've found that if there's a part of a polyp that's really hard to access with gas insufflation, that oftentimes underwater it's still quite difficult to access. So it may be helpful to inject that part first, and that's what I've done with this polyp that's adjacent to the ileocecal valve. Part of it is on the proximal side of this fold and part of it is distal. So I injected the portion that was on the proximal side to sort of roll it up, haven't injected the distal side, and then we've gone underwater here and we're starting at the distal edge and removing that, and then we're going to move across the lesion. We're going to move toward the more proximal aspects and stay underwater as we're doing the resection. And you can see that the blue submucosal defect where the injection occurred and the sort of white submucosal defect where there wasn't any injection. But I found that that initial injection makes that portion of the polyp easier to access even underwater. There you can see the defect in air after the resection has been completed. So I recommend in some instances this hybrid approach to EMR.
So underwater EMR is a new technique, and we need to congratulate Ken Binmoller on the development of this technique. Certainly it's going to be subjected to a lot of study and comparison to standard techniques, but it shows a lot of promise and it warrants our consideration. That's the ASGE Tip of the Week. The Tip of the Week is brought to you by an educational grant from Braintree Laboratories.